Okay, so this is a digestive system chapter, and what I want you to recognize is that you still have to read all of your PowerPoint slides that you have. What I'm going to be doing is a voiceover for specific PowerPoints that need explanation or for me to introduce a concept or something like that. So the way it works is if I don't say anything on a slide, it skips over that slide so you won't see it in this video. However, that doesn't mean you don't need to read it and study it. So I'm not going to just read slides to you. I want to explain the concepts in here and make sure you have the lecture portion that you need. Okay? So make sure you're reading your PowerPoints as well as watching the video. So there are 6 processes in the digestive system that take place. The ingestion of food, where we take it in. The propulsion, or moving the food along through peristalsis, and that happens from the smooth muscle contraction. Mechanical digestion, which is the physical breakdown of the food. Chemical digestion, which is the chemical breakdown of the food. And then once it's completely broken down, we will absorb those macronutrients. And then whatever we don't absorb, then we will get rid of and eliminate through defecation. So remember, in the respiratory system chapter, we had pleura, that serous membrane that covered the lungs and thoracic wall. Well, in the abdominal cavity, we have what's called peritoneum. So it's also a serous membrane. You have the visceral peritoneum. That covers the organs in the abdominal cavity, and the parietal peritoneum lines the abdominal body wall. And and there's also a peritoneal cavity, just like there was a pleural cavity in the thoracic cavity, in the thoracic area. And so what that does is it lubricates the digestive organs, also allows them to slide, or that lubrication allows them to slide across one another. Mesentery is a double layer of peritoneum. It has nerves and blood supply in it. It also helps hold digestive organs in place and stores fat. You'll see those oftentimes in the intestines. Between the intestines, you'll see those. And so those are actually a type of, or double layer of peritoneum. So the 4 layers of the digestive tract or alimentary canal, those are the same thing. They're also called tunics. Those 4 layers are the mucosa layer, the submucosa, muscularis externa, and serosa. This is going from the inside to the out. Make sure you memorize kind of that pathway. And it makes sense. Mucosa we know is always on the inside, serosa on the outside. Submucosa must be right next to the mucosa, right? And then the muscularis externa, that 3rd layer, that is actually where we have the smooth muscle that's going to propel the food along through peristalsis. So you've got the mucosa layer, and there's 3 major functions there. You have secretion of mucus, obviously, right? Because there's goblet cells in there secreting mucus. You absorb things in the mucous membrane here, mostly in the small intestine. And then also protection, because we know the mucus has like lysosomes and defensins and things like that. Now there's some subparts that will go on the next slide of the mucosal layer, so sublayers. If we look here, the first sublayer is just the simple columnar cells that have the goblet cells in them, those mucus secreting cells. The lamina propria is the next sublayer, and that is where we absorb nutrients in the appropriate places where we do absorb nutrients throughout the digestive tract. Now keep in mind, all 4 layers are throughout the entire digestive tract, but there's different specializations in each section of the digestive tract. Okay? You also have those mucosa-associated lymphatic tissues here that we talked about in the lymph system chapter. And then a muscularis mucosa sublayer. This is smooth muscles. It helps move the mucus along. This is not what moves the food along. Okay, this is a sublayer of the mucous membrane. The submucosa contains a number of things like lymph nodes and nerves and blood vessels, and so that's our 2nd layer. As we move into the muscularis externa layer, this one is the one that's responsible for the peristalsis, right? The movement of the food, bolus, chyme throughout the digestive system, and we're going to go through that as we go through each section. And the muscularis externa, it has an inner circular layer and an outer longitudinal sublayer. And then when we get to the stomach, we're going to see an oblique layer, an additional layer, a sublayer within this layer of the digestive system. And then the last outside layer is the serosal layer, right, which secretes the serous fluid and helps lubricate the organs so they don't stick together, and there's no friction, things like that. As I mentioned, just a reminder, things like this where it talks about the mouth and the functions, and so you're gonna read this on your own rather than me read the exact slide to you. Sometimes I will read them to set up something for the coming physiology, but I think some of these are straightforward, so don't forget to read your slides, just a reminder. The one thing I want to comment on this slide is the function of the soft palate. Is when we swallow, it closes off the nasopharynx. So that again, what we're trying to do, remember the epiglottis goes over the larynx, it closes off the air tube, and then the soft palate is going to flap up to close off the nasopharynx so that food will go down the esophagus. The tongue has two sets of muscles. We have intrinsic muscles that change the shape of the tongue and extrinsic muscles that alter the tongue's position. And so it's going to move food around, right? So when you're chewing, it's going to assist in that. It's also going to mix the saliva with the enzymes in it with the food, and then that's what we call a bolus. Once we mix the saliva and enzymes in the mouth, the juices in the mouth, with the food, it's no longer called food, it's called a bolus. And then the tongue also initiates the swallowing by tossing the food to the back of the throat. And of course, we know the tongue is also involved in speech. And the little spiderweb looking thing at the bottom of your tongue that anchors the tongue to the roof or the floor of the mouth is called the lingual frenulum. Now you do have these lingual glands. Okay, we're going to talk about other glands in a little bit that secrete different enzymes, but the lingual glands are within the tongue and they secrete something called lingual lipase. Well, oftentimes, ASC we know is enzyme, right? And oftentimes they're named for what they digest. So this is obviously going to digest lipids. And so lingual lipase is this digestive enzyme that breaks down fat. However, very, very important, this enzyme is only activated in an acid environment, so it won't become activated until it reaches the stomach. So what it's going to do is it's going to mix with the food that becomes a bolus. It's going to hitch a ride with the bolus down to the stomach. When it gets to the stomach, it becomes active. It is not active in breaking down fat in the mouth. So again, on this slide, you're memorizing the functions of the salivary glands. This is general functions. We're going to break it down into extrinsic and intrinsic on the next slide. Your extrinsic salivary glands are going to be your parotid glands, your submandibular glands, and your sublingual glands. These are going to produce an enzyme called salivary amylase. Whenever you see the word amylase, you're thinking a carbohydrate digesting enzyme, because later on we're going to see a pancreatic amylase. And so then we also have intrinsic salivary glands, also called buccal glands. And these guys are just really going to produce some fluid to help keep the mouth moist. And so both are essential in this bolus formation. On this slide, you can see the parotid gland, the submandibular, and the sublingual gland all producing salivary amylase. Now, salivary amylase, we said, digests carbohydrates. This is a chemical form of digestion. The macronutrients, we have protein, carbohydrates, and lipids. The only thing that is chemically digested in the mouth is the carbohydrates with the salivary amylase. All three, however, are mechanically digested in the mouth by the process of chewing, the physical breakdown of all three types of macronutrients. So what causes the salivary glands, or the extrinsic salivary glands, to secrete that salivary amylase? Basically, it is a couple of things it could be. It's ingestion of food, and when we put the food in the mouth, there's chemoreceptors and some stretch receptors, these pressure receptors that help us sense that we've got food in there. We need to secrete these enzymes to break them down. And also, though, the thought of food. So even thinking about food, we start to salivate, okay? And that in preparation for the breakdown of the incoming food, because when we think about food, the body thinks, okay, food's coming soon, all right? And then also on this slide, xerostomia, just so we know a little medical terminology here, it translates as dry mouth. We don't cover a ton of information on teeth, but I want you to know that the primary teeth, we have 20 deciduous teeth, and then our permanent teeth, we have 32. Know those numbers. This slide I have underlined for you the functions of each type of tooth. So the incisors will cut and nip, the canines will tear and pierce, and the premolars, the bicuspids, and the molars will grind and crush. So memorize the functions of the different types of teeth. Enamel is the hardest substance in the body. The rest of the stuff on these couple of slides, primarily you're going to see is talking about the anatomy, which you study for lab. The periodontal ligament is what anchors the tooth into the alveolar process and to form that gum fossa that we talked about in Anatomy and Physiology 1. And there is this stuff called cementum that actually attaches the tooth to the periodontal ligament. Here's a picture of the tooth and all of the structures and functions. I'm just going to remind you to study this for your lab exam. Now, dental caries, what are they? Well, these are essentially cavities, and it's a demineralization of the enamel and dentin that's caused by bacteria, right? Bacterial action. And so what's going to happen is this plaque is going to build up, which is a film of sugar, bacteria, debris, and this stuff adheres to the tooth. The bacteria produce acid, and it starts to dissolve the calcium salts in the tooth, and then it exposes them to these proteolytic enzymes, that'll start to create little pockets in the tooth and kind of eat away at the tooth. And so flossing and brushing, very essential for preventing dental caries and removing these plaques. Gingivitis is a dysfunction where you have plaque that calcifies, forms tartar, which is a calculus, it's called. The calculus disrupts the seal between the gums. The gingiva are the gums, between the gums and the teeth. Bacteria get in there, they infect the gums. Now this is reversible once the calculus is removed. Now remember, gingiva is gums, itis means inflammation, so this is an inflammatory situation with your gingiva, your gums. Periodontitis, however, also called periodontal disease, this is autoimmune because your immune system cells actually attack your body's tissues. The tissues that get attacked in periodontitis are the periodontal ligament, which we said anchors the tooth in the socket, which means tooth loss is one of the side effects here of periodontitis. It'll also activate osteoclasts and start to eat away at the bone. So tooth loss, but there's other things. Because this is an inflammatory process, it promotes atherosclerosis and some risk factors, smoking, which is a risk factor for everything, diabetes, mellitus, tongue or lip piercing. These are some of the risk factors that increase the risk for periodontal disease. So let's review the process that we did in the mouth so far. We ingested the food, we mechanically broke down carbohydrates, proteins, and lipids through mechanical digestion of chewing, then we move this stuff through, right? We swallow it. That's called deglutition. We're going to talk a little bit more about that on the next slides. Salivary amylase was produced here that chemically broke down carbohydrates, specifically the starches. And then we produce lingual lipase here in the mouth, but it's not activated until it gets down to the stomach. And that kind of is where we're at right now. So we take this thing that's food, we mix it with all this fluid and enzymes, and then it's called a bolus now. And then we take that bolus and we're going to toss it to the back of the throat and swallow it down and bring it down through the esophagus, through peristalsis, into the stomach. That's where we're going next. So here's the process of deglutition, which is swallowing. We have the buccal phase, which is that part where the tongue is throwing the food or the bolus to the back of the throat. This is voluntary. Now understand, there's 22 separate muscles that are actually involved in deglutition. And then we have a second phase called the pharyngeal esophageal phase. And this one is, this is not consciously controlled, it is involuntary. And what it does is seals off all the roots, right? We said that the nasopharynx will be closed off by the soft palate and the epiglottis will close off the larynx. And so the food will move into the esophagus and then move down the esophagus, as I said before, by peristalsis. You can see the process here of deglutition, but also the food or the bolus moving down the esophagus and through. You can't really see it well here, but there's at the bottom of the esophagus, there's a gastroesophageal sphincter, also called the lower esophageal sphincter, and more commonly known as the cardiac sphincter. So the bolus is going to move through that sphincter into the stomach. Now in the stomach, we're going to have chemical breakdown of protein beginning. We're also going to have a little bit of chemical breakdown of fat beginning. But let's just start here. Once we mix the bolus with the digestive juices in the stomach, it is now called chyme, C-H-Y-M-E. And so we're going to chemically break down some proteins here. We're going to chemically break down some fats because that lingual lipase will become activated. We're also going to secrete gastric lipase that'll become activated, but it only does a little bit of fat digestion. Most of that's going to happen once we get to the small intestines. Now we do mechanical digestion in the stomach as well. There's only two places we do it. We do it in the mouth, we do it in the stomach. In the mouth it's teeth, chewing, and in the stomach it's this oblique layer of muscle. It's an additional sublayer of the muscularis externa, and it's going to contract and when it does, it's going to mix and churn and pummel the food and physically kind of mash it and break it down. And again, mechanical digestion is non-specific, so it's always going to be all three macronutrients, right? Carbohydrates, proteins, and lipids, okay? And then once we're done, once we move it through the stomach, we're going to move it through the pyloric sphincter, also called the pyloric valve, into the duodenum, which is the beginning portion of the small intestine. But I'm going to be covering here the specifics of the chemical digestion of the proteins. On this slide, you can see that additional layer, that oblique layer of muscle that's responsible for the mechanical digestion in the stomach. Now we're going to see on a future slide here that we have some specializations in the stomach that allow it to have this acidic environment. So it's built for acid, whereas other parts of the digestive system are not. And so one of the specializations is that the goblet cells in the stomach lining produce an alkaline mucus. And so what it does is this bicarbonate-rich mucus lines the surface and protects the surface from the acid that will be produced, down in the gastric glands. And we're going to talk about the different cells. On this slide, you can visualize the different cells. We have the mucous neck cells. They're actually going to secrete an acidic mucus, but they're down below the gastric pits in the gastric glands there. And so it's not on the surface. On the surface, we're producing an alkaline mucus. And then we've got parietal cells, chief cells, and these enteroendocrine cells, which I'll talk about on the coming slides. So the different types of cells. I already mentioned the mucous neck cells produce this acid mucus. The parietal cells are going to secrete HCl. This is very important, hydrochloric acid. They also secrete something called intrinsic factor, which we mentioned in previous chapters. And intrinsic factor is necessary for the absorption of B12, right, or 99% of the B12 that we absorb. Okay, so chief cells produce gastric lipase, which is very similar to lingual lipase. That's going to help the digestion of lipids chemically. The pepsinogen is also produced by the chief cells, and that is an inactive enzyme. So here's the process that happens for digestion of protein. We've got the hydrochloric acid produced by the parietal cells. That is going to convert the pepsinogen into pepsin. Now, pepsin is the active enzyme. And so what pepsin does is it breaks peptide bonds, which are the bonds between amino acids. And so this is going to be chemical breakdown of proteins, right? And so now if you look on this, you see how pepsin arrows down to another pepsinogen. What it does is when HCl converts pepsinogen to pepsin, pepsin not only breaks peptide bonds, it also converts other pepsinogen to pepsin. And that's what we're talking about with the positive feedback. So pepsin converts more pepsinogen to pepsin, and that pepsin converts more pepsinogen to pepsin, and we get this big pool of pepsin to digest peptide bonds. Now we're going to talk about also with HCl here that HCl also will denature the protein. Why do we denature the protein? Well, it's a globular protein, and some of those peptide bonds are on the inside, so we have to unfold the protein to get to those peptide bonds. So the HCl not only converts pepsinogen to pepsin, but it also will unfold or denature the protein, and by doing that, it exposes the peptide bonds on the inside to the pepsin, and thereby we can break down those peptide bonds. Now, so those are two functions of HCl. Three more functions of HCl that I want you to memorize. HCl also is necessary to break B12 away from food. And you say, Dr. Lamont, I thought you said that intrinsic factor is necessary to absorb B12, and yes, that is correct, but first we have to break it away from food, and HCl will do that. We also have to, HCl will also break minerals like calcium and zinc and things like that away from food so that you can absorb those, because there's things in food, some things in food that can bind those minerals like phytates and oxalates and things like that. So we got to break it away from those. And then lastly, the HCl creates an environment that decreases bacterial infection in your stomach. So if we were to say, if someone takes long-term proton pump inhibitors that blocks HCl, what's going to block all these functions? Long-term, it can cause mineral deficiencies. Long-term, it can cause B12 deficiency. Long-term, it can cause protein malnutrition and also increase the risk of bacterial infection in the stomach. So they were never meant for long-term proton pump inhibitors like Nexium and Prilosec. If we stay on them too long, it can cause some of these problems. This slide, you see kind of the pepsinogen converting into pepsin with the HCl, just a different visualization here, and you can see the cells up close. The last cells will cover the enteroendocrine, and that'll be on the next slide. But whenever we think endocrine, we're thinking some kind of like hormone or hormone-like substances. Entero, we think intestines, or in this case, intestines or stomach, because we're going to have enteroendocrine cells in the intestines as well, but they're going to produce different things. And so let's go to that next slide. So enteroendocrine cells in the stomach produce, we have some that produce serotonin, which is actually not only a neurotransmitter in the brain, but increases intestinal motility. We have the ones that produce histamine, which is a vasodilator we learned about before. And then we have some hormones produced here, like somatostatin, which is going to inhibit gastric secretion, and gastrin, which actually increases gastric secretion. I would say the most important of these for you to memorize is going to be gastrin, because we'll talk about that one in the future again. But again, know all of these as far as chemicals that are produced by enteroendocrine cells in the stomach. Don't get confused when we get the small intestines. The enteroendocrine cells in the small intestines are different ones, and they produce different hormones. This slide talks about the different specializations. Now, we covered one of them. We said that the The lining of the stomach produces this bicarbonate-rich mucus that's an alkaline mucus that helps protect the stomach. And then also we have tight junctions between epithelial cells so there's no leakage. Thirdly, we have gastric glands that are impermeable to HCl. So in those glands, the HCl that's produced, it won't damage those cells because they're impermeable to it. And then lastly, number 4, the epithelial cells replace really quickly. And so the ones that do get damaged, we generally replace really quick. Now, some dysfunctions or homeostatic imbalance of the stomach. We have gastritis. Okay, now if it doesn't fall in the category of ulcer or gastroesophageal reflux, which we'll cover those, then it's generally categorized as something like a non-specified gastritis, which is inflammation of the stomach. It's anything that breaches the mucosal barrier can cause gastritis, so there's a number of different factors. But let's talk about ulcers. Peptic ulcers, most people assume, stomach. Well, peptic ulcer is one of 3 types of ulcers. We have gastric ulcers, which are the stomach. We have esophageal ulcers, which is in the esophagus, and duodenal ulcers in the duodenum, which is the beginning portion of the small intestine. All of those are peptic ulcers. The most common are the ones in the stomach and duodenum, so the gastric and duodenal. Now, most peptic ulcers are caused by Helicobacter pylori or H. pylori bacteria. It's not the only cause, although on an exam, if I said what's the most common cause or significant factor, you would say H. pylori or Helicobacter pylori. However, there must be other factors. We'll see on the next slide here. If you look at the statistics here, okay. The risk of developing peptic ulcer disease in people that are infected with H. pylori is about 10 to 15%. But about 50% of the people in the world have H. pylori. So you see that there's only a small percentage or a percentage of those 50, right, 10 to 15% of those 50% that are actually exhibiting these ulcers, these peptic ulcers. And so that means that our body usually fights off the Helicobacter pylori, but there are a number of other factors that could increase the risk. So if you combine enough factors, then you wind up with one of these peptic ulcers. NSAIDs, nonsteroidal anti-inflammatories, and aspirin account for about 15 to 30% of gastric ulcers. You have some other factors besides NSAIDs that contribute to peptic ulcer disease, which is gastrin-secreting tumors, tobacco, steroid use, renal failure, COPD, stress, and trauma. And don't forget, stress increases cortisol levels. Cortisol disrupts the stomach and the intestinal, actually the stomach, disrupts the stomach and increases, acidity and things like that. So those are factors that contribute to peptic ulcers. So on the left is a gastric ulcer, and on the right you can see, look at those little guys, H. pyloris, they're disgusting. Now, the H. pyloris will corkscrew into the mucosal lining again. They're opportunistic type infections where, if we have a healthy immune system, we usually kill these things off, okay? However, if you have an infection, you're going to want to take an antibiotic to kill that thing because, again, if you have gastritis and this H. pylori, you wouldn't know you had H. pylori because they wouldn't test it unless you actually had gastritis symptoms. However, you do want to make sure you take something to kill that if you do have it. Now, a gastric ulcer, when we look at that, people are like, it's a hole in the stomach. Well, it's a hole in the lining. It's kind of like similar to a hole in the ozone layer. There's no such thing as a hole in the ozone layer. A hole in the ozone layer is actually a decreased density of the ozone. So when it decreases to a certain point, they call it a hole. Same type of thing with the hole, quote unquote, or ulcer in your stomach. When you eat through the mucosal lining, you didn't go through the entire all 4 layers, but when you eat through the mucosal layer and you get into that next layer, now it's an ulcer, okay? Another dysfunction is gastroesophageal reflux, also known as GERD. And what happens here is the acid from the stomach breaches that cardiac sphincter and gets into the esophagus that is not built for acid. And so it can actually scorch the esophagus, it causes inflammation, potentially esophageal ulcers, and long-term esophageal cancer risk. A common cause, and probably the most common cause of GERD, is a hiatal hernia. It weakens that sphincter, that gastroesophageal sphincter, which is the cardiac sphincter. It weakens that sphincter so it doesn't close efficiently, and then acid will breach it, and I'll show you a picture on the next slide. So we look here, you can see the acid actually breaching the esophageal, lower esophageal sphincter, also called gastroesophageal, also called cardiac sphincter. I don't know why we need 3 names for it, but we have 3 names for it. But when the acid breaches up there, that's gastroesophageal reflux. This is not just heartburn. You know, you eat grandma's spicy tomato sauce and you had a little heartburn. No, this is actually a dysfunction in the valve where acid continues to breach through there. It can cause some long-term effects. It can even you can lay down, go to sleep, and this acid can breach into the throat. It can get into the bronchial tree. I know of actually it was a husband of my former patient of mine, wound up having pulmonary fibrosis from long-term gastroesophageal reflux. And so not good stuff. Here you can see a couple of pictures of a hiatal hernia. These are pretty significant. If the hiatal hernia is minor, you can manage it, you know, through diet and things like that, where, you know, if you don't eat, you know, high acid foods or eating a lot before you go to sleep, it's usually pretty manageable. You don't have much reflux. But these probably need surgical intervention. These are pretty significant. All right, let's sum up what we did in the stomach so far, right? We put food in the stomach and we're going to mechanically break down all three macronutrients: carbohydrates, proteins, lipids, right? The physical breakdown by the churning caused by that oblique muscle layer. Chemical digestion, we chemically digested lipids a little bit with our lingual lipase and our gastric lipase, but we really need to break the lipids down into digestible chunks for those lipases to work better. We're going to do that in the small intestines. We chemically broke down protein here with the whole pepsinogen to pepsin thing and the HCl causing the unfolding of the protein, right? The denaturation of the protein. By the way, we also turned bolus into chyme here when we mixed it with the gastric juices. By the way, the pH of the stomach, I didn't mention earlier, but the pH of the stomach is about a pH of 2. pH of HCl is 0. And so when you mix that with some of the other juices, you get a pH of around 2, which is highly acidic. And now, what else do we have? Oh, intrinsic factor was also produced here, and that's what was necessary to absorb 99% of your B12 to prevent, you know, pernicious anemia. All right, so that kind of sums up the stomach. Then we're going to move things slowly through the pyloric sphincter into the smaller tube now, the duodenum, right? We're going from a bag, the stomach, into this small tube called the duodenum. There are 3 phases in the regulation of gastric secretion. There's stimulatory and inhibitory events that occur in these 3 phases. And the phases can be occurring at the same time or individually. And so the cephalic phase is before food enters. It only lasts for a few minutes. And so the second phase is the gastric phase. That's once the food actually enters the stomach. This lasts for about 3 to 4 hours. And the intestinal phase is as we're moving the food slowly into the duodenum. Now, gastric emptying is regulated both neurally and hormonally. The neural is a reflex called the enterogastric reflex. Okay, that's going to inhibit gastric secretion and duodenal filling. And then same thing for the hormone called enterogastrone. That's also going to inhibit gastric secretion and duodenal filling. And so those will help regulate the emptying of the stomach. The term emesis, just I want you to be familiar with, just means vomiting. And so if you are looking at medications and it's an emetic, that means it induces vomiting. Holy sloppy writing, Batman, but that's okay. I wanted to write some things on here for you. When we talk about movement through the digestive system, carbohydrates are going to move through the fastest. Fat is going to take the longest to move through. When we talk about the term satiety, it means feeling of fullness. Proteins make you feel the fullest fastest. Lipids do not make you feel full right away, but they will make you feel full the longest because once you hit the small intestines, it takes a long time for them to digest, so it gives you a long-term satiety. And this is why I always recommend to people eating all 3 macronutrients in every meal. Good carbohydrates, protein, and good lipids. And it does help facilitate the feeling of fullness, as well as give you the essential macronutrients you need. The 3 sections of the small intestine are the duodenum, jejunum, and ileum. They're about 6.5 to 13 feet long. But we're going to see that there's some folds inside that will actually increase the surface area, as well as these little finger structures called villi, and we'll talk about that in just a little bit. We're going to talk a little bit about the liver and gallbladder, and then get into the small intestines. So if you go and look forward ahead and you look at the pictures, the common bile duct, and I cover this stuff in lab, and the main pancreatic duct go into the small intestines through a little widening point. Ampulla means widening point. Through a little widening point called the hepatopancreatic ampulla. And another name for it is, and then there's a sphincter around it, a ring of muscle called the hepatopancreatic sphincter, and that has another name called the sphincter of Oddi. And that sphincter regulates the entry of the bile from the common bile duct and the juices from the main pancreatic duct into the small intestine, which is, after we go through a little bit of this anatomy, we'll talk about the digestion in the small intestine. Now, to get to the large intestine, there's an opening or a valve called the ileocecal valve. That ileocecal valve or sphincter regulates the movement of the chyme from the small intestine into the large intestine. Once we move into the large intestine, the chyme is now called feces. So it becomes chyme in the stomach, it's chyme all throughout the small intestines, and then we move it through the ileocecal valve into the large intestines. I want to just talk a little bit about this slide. You can see the left and right hepatic ducts coming together to form the common hepatic duct. You can see coming from the gallbladder the cystic duct that joins with the common hepatic duct, and it makes the common bile duct. I know the textbook says bile duct here, but remember, you're always going to put common bile duct on my exams. And what's going to happen is, you see that common bile duct coming down, you can see the main pancreatic duct. They both go through that little triangle portion called the hepatopancreatic ampulla, which is surrounded by the hepatopancreatic sphincter. Just keep in mind, you're like, hey, are they the same thing? No. The ampulla, they're pointing to the same place because the ampulla is basically the cone, and the sphincter is the muscle that wraps around the cone. Okay, that's the sphincter. All right. On this slide, it shows the circular folds, which are also called plicae, or actually their name is plicae circularis. But you see how if we unravel the intestines, how you've got these circular folds? And so it could be 6.5 to 13 feet long, but if we unfold all of those folds, it becomes exponentially larger, a larger surface area, which is going to be important because the more surface area we have, the more area we have for absorption. Now, we'll look at the next slide. We'll see the villi, the little finger structures that are on the plicae circularis. So here we see the villi, the fingers, and so these are little fingers on those folds. If we unraveled all those, we have even more surface area. And then if you look at the ends, you have to zoom in and look at that picture where it's zoomed in. You can see the microvilli. They're like little hair-like structures on the villi. And it's also called, they create what's called a brush border. It's going to be important because we'll talk about how we produce some enzymes in that brush border. Also, that's where absorption is going to take place into those cells called enterocytes. Cyte means cell, entero, we think intestine, so enterocytes are the cells of the villi that you can see as we look at that cross-sected, or well, it's not a cross-section, but look at that cut of the villi where we can look inside it. We can see those cells. They're calling them absorptive cells. Those absorptive cells are enterocytes, okay? They call them absorptive cells because we're absorbing through, right, in the small intestines where most absorption happens, we're absorbing the nutrients into there. And then you can see that green thing inside of it. That's the specialized lymphatic capillary called the lacteal. We'll be talking about the functionality of this in future slides here. So the absorptive cells are those enterocytes we talked about. That's where you're going to absorb nutrients. At a slide a little bit later in here, it talks about how most of the nutrients are absorbed in the small intestine. You also have the microvilli that we talked about also on the previous slide, and that creates a brush border. And that brush border produces enzymes. If we look down here, we have enzymes for carbohydrates, dextrinase, which digests dextrose, maltase, which digests maltose, sucrose, and lactase digest lactose. And so, in fact, that's the enzyme that's deficient in someone that has lactose intolerance. If we look at the proteins, we have some protein digesting enzymes. We're not going to focus on the nucleotides at all. So we're producing these enzymes here in this portion of the small intestine. We also have goblet cells, of course, which we have throughout the entire GI tract that secrete mucus. Some other cells we have found within these intestinal crypts called the crypts of Lieberkühn. There are enteroendocrine cells, which I told you we were going to get to that, right? That there were going to be enteroendocrine cells in the small intestine, and they're going to secrete secretin and cholecystokinin, which I will cover later in this chapter. There'll also be some T cells, which you know what those do from the immune system chapter, as well as these other cells called Paneth cells that secrete defensins and lysosomes, which are antibacterial. Another specialization you'll see in the small intestines, we have these Peyer's patches, and we saw those in the lymphatic system chapter. We also have these in the duodenum portion of the small intestine. You have duodenal glands, or they're also known as Brunner's glands, and these glands will secrete an alkaline mucus. Now this makes sense, right? Because we're moving fatty acidic chyme right? Because we're coming from an acid environment into the duodenum. So this gland secretes this alkaline mucus to protect that beginning portion of the duodenum until we change the environment and that chyme into a more alkaline environment. Make sure you memorize that the liver is the largest gland in the body. The rest of this stuff is anatomy that you'll look at with lab stuff. We've talked about macrophages before. The macrophages that are housed within the liver are called Kupffer cells. But then you have hepatocytes, which are your normal liver cells, and those are going to do a number of functions. They're going to produce bile. They're going to process bloodborne nutrients. We have the hepatic portal vein that's going to shuttle things from the small intestines directly to the liver for processing. We're going to store fat-soluble vitamins here. And this is also important for detoxification, and most people know that, right? So there's something in the liver called the microsomal ethanol oxidizing system, and that's going to break down alcohol and drugs and toxins and things like that. And then the fifth thing is the production of procoagulants, right? Some of the clotting factors that we talked about before in a different chapter. So that's the one I added down there, number 5. Hepatitis is inflammation of the liver. We know whenever there's an itis, it's an inflammation, and hepato is liver. So hepatitis is inflammation of the liver. It's usually due to a viral infection. The most common types are hepatitis B, A, and C. B being the most common. This is transmitted through transfusions, contaminated needles, or sexual contact. You also have hepatitis A, which is transmitted through contaminated food, water, or feces to mouth. And hepatitis is more common in men. This slide talks about hepatitis C, which is the chronic liver infection. And when you have chronic hepatitis, it can lead to cirrhosis, which is degeneration of the liver, which we'll talk about. I believe it's on the next slide. This is transmitted through blood. So cirrhosis is this progressed degeneration of the liver, and there's stages that it goes through. The most common causes for this are going to be chronic alcoholism and then severe chronic hepatitis. And the stage of degeneration, or the first stage, is going to be fatty liver. The second stage of degeneration is fibrosis, and then it ends up with cirrhosis. And as the liver degenerates, the function degenerates with it, and we just looked at the functions just a little bit ago here. So this is talking about the composition of bile, and while I don't want you to know everything that's in bile, I would like you to be aware that there's a pigment in there called bilirubin. It's a waste product of heme, and that is actually used as a direct and indirect that's used to kind of assess liver function and or dysfunctions, I should say. And but I also do want you to know that the key component that we're focused on here is bile salts, because bile salts and what their function are, it's going to emulsify the fat. Emulsification means to break down into these digestible fatty droplets. I don't know if you remember me saying before, but the lipases weren't really effective, not very effective, because we needed to break this fat down into digestible portions. And so the emulsification does that. If you want to visualize what emulsification is, if I took liquid detergent and I had oil in a pan and I put the detergent in the pan, the oily pan, the pan with the oil in it, what happens? The oil separates into droplets. And so that's your visualization of what emulsification is. Another thing these bile salts will do is it'll actually facilitate the absorption of fat and cholesterol and help solubilize cholesterol. And you'll see that a deficiency in these can actually lead to gallstones. We'll talk about that on a different slide. All right, so we said that the liver makes bile, but the gallbladder is going to store and concentrate that bile. So actually the bile in the gallbladder is about 10 to 20 times more concentrated than what is actually made by the liver. Now, cholelithiasis, when you think chole, we usually think gallbladder. Lith is stone, iasis is formation. So this is the formation of gallstones, and it can happen primarily from 3 causes: excessive cholesterol, or an insufficiency in bile salts, or an insufficiency in lecithin. Those are the common causes. This is more common in females than males, and that's due to estrogen imbalances. And the treatment is certain drugs to dissolve the gallstones, or shockwave lithotripsy that's supposed to shatter the stone. It's an ultrasound. If those don't work, then surgical removal of the gallbladder, which is called a cholecystectomy. So the pancreas, we know, is both an exocrine and an endocrine organ. We learned about its endocrine function, which is only 1% of the cells, the islets of Langerhans, also called pancreatic islets, that had the alpha and beta cells. The alpha that produced the glucagon, the beta cells that produced the insulin. But the exocrine function, the other 99% of the cells, called acini or acini cells, those are the ones that produce the digestive juices that we're going to talk about. So there's two components to the juice produced by these acini cells. You've got this bicarbonate-rich juice that's going to neutralize the acidic chyme coming into the duodenum. And then you have enzyme-rich juice, which is going to have pancreatic amylase, and we said amylase digests carbohydrates. We'll have pancreatic lipase, that digests lipids. And then, and those are in active form. They're already active. We also secrete proteases, some protein-digesting enzymes in that pancreatic juice, or that enzyme-rich pancreatic juice. But those are in an inactive form, and they need to be activated, which I'm going to cover on the next couple of slides here. Okay, so the pancreatic proteases that get secreted are inactive. We have to activate them. So there's an enzyme in the brush border, that's the microvilli, called enteropeptidase. That is going to convert one of the proteases made by the pancreas called trypsinogen into trypsin. And then the trypsin will go ahead then and activate other proteases into their active form. And so you see I wrote that on that little flow chart there. So don't worry so much about the name procarboxypeptidase and chymotrypsin or their active forms. We're just going to call them other proteases, and then they will be converted to their active form by trypsin once trypsinogen is converted to trypsin by that brush border enzyme enteropeptidase. Now you'll see in your slides that I've got a few slides that explain cholecystokinin and secretin. Now I'm going to summarize it all up on this slide though, so you won't actually see all of them on the video here. But I do want you to know the functions of cholecystokinin and the functions of secretin. First, what causes these to secrete? Well, the presence of fatty acidic chyme entering the duodenum causes the intestines to make these two intestinal hormones. So it makes cholecystokinin and it makes secretin. These are intestinal hormones. Here's what secretin is going to do. It's going to go to the liver and it's going to cause the liver to secrete more bile, okay, or produce more bile, I should say. And it's also going to go to the pancreas and cause the pancreas to secrete the bicarbonate-rich fluid. So remember we said this bicarbonate-rich fluid and enzyme-rich fluid from the pancreas. Secretin specifically stimulates the release of bicarbonate-rich fluid. Now what does cholecystokinin do? One thing it's going to do is it's going to go to the pancreas also, but it's going to cause the pancreas to release enzyme-rich pancreatic juice. It's going to go to the gallbladder, and it's going to cause the gallbladder to contract, which is going to release bile, because we know the gallbladder is a storage for bile. It also concentrates that bile. So it's going to cause the gallbladder to contract, releasing bile. One more thing it has to do. Well, in order to get the juice from the main pancreatic duct and the bile from the common bile duct into the duodenum, what do we have to do? Well, there's a little sphincter guarding that opening, right? That hepatopancreatic ampulla. So that sphincter, called the hepatopancreatic sphincter, must relax. So the cholecystokinin will cause relaxation of the hepatopancreatic sphincter. Don't forget it's also called the sphincter of Oddi. So it's going to relax that sphincter and allow the bile and the pancreatic juices to flow in. So those are the functions of both cholecystokinin and secretin, and they are secreted from the intestines when fatty acidic chyme enters the duodenum. This gives you kind of an overview of what I just said, but also what I want to emphasize is that stimulation from the vagus nerve, cranial nerve 10, will also cause weak gallbladder contraction, and it will cause a weak secretion of these pancreatic juices as well. So you do have, this is a primarily hormonal stimulus with CCK and secretin. However, vagal stimulation will cause the release of some of this as well. And this is all in your notes. As I said a few times in this chapter, most nutrient absorption, almost all of it, takes place in the small intestine. So there's a reflex. When we put food in the stomach, we secrete gastrin, which is a hormone, but also the presence of food in the stomach triggers this gastroileal reflex. So both the gastroileal reflex that reflex is caused by the activity in the stomach, and the hormone gastrin, which increases gastric secretion. Both of those will actually cause a relaxation of the ileocecal valve or sphincter, which again goes from the ileum of the small intestine into the colon, and then we can move the chyme in there. And the reason for this is we have food in the stomach that's going to go into the small intestine, so we've got to get the stuff in the small intestine out into the colon, right, into the large intestine, so we can get rid of it and make room. For the slides looking at the anatomy of the colon, we're going to mainly focus on your lab material for that, but here's a picture with all of the related structures. Now you have an internal anal sphincter and an external anal sphincter. The internal anal sphincter is smooth muscle. That means it's involuntary. The external anal sphincter is made of skeletal muscle. That means it's voluntary. Now in addition to those sphincters, you do have some rectal valves. The rectal valves are just to prevent the passage of feces when you pass gas. The actual internal and external anal sphincters is what regulates the movement of the feces out of the colon. Here's the visualization of those sphincters as well as the valve. Now it looks like there's two, but remember when it's a ring of muscle, when we cut it like that, it looks like there's one on each side, but it's actually one internal anal sphincter and one external anal sphincter. Hemorrhoids are simply inflammation of the veins in the rectal anal region there, and it results in varicosities is what they're called. And so you can have internal hemorrhoids or external hemorrhoids. Both bleed. The internal are not painful, the external are, and the actual varicosities prolapse outside of the anal canal with the external. So when we look at bacterial flora in the large intestine, we're talking about these populations of bacteria. And so they are going to colonize the colon. Some of these bacteria are going to actually ferment indigestible carbohydrates, so things like stachyose, which is a sugar that's found in beans that we do not have the enzyme to break down, and so it's a disaccharide that's going to be fermented, and then that produces gases and things like that. Same thing happens with lactose. If you're lactose intolerant, you don't break down the lactose, which is a disaccharide, the bacteria will ferment it, and then again it causes this gas and things like that. Also, the bacteria are responsible for producing biotin, one of the B vitamins, as well as vitamin K. It is estimated that about 50% of your vitamin K comes from the bacterial flora in your colon. And so it says on this slide B complex, but we're going to focus on biotin because we're not really sure if it does produce some of the other B vitamins or how well we absorb them. Now, while we can absorb vitamins, water, and electrolytes from the large intestine, we're not breaking anything else down here. The only breakdown that would occur in the large intestine would be the fermentation from bacteria breaking things down, but we don't break anything down at this point. Now, remember we said we had a gastroileal reflex, well, we have something called a gastrocolic reflex also. And so when there's food in the stomach, not only do we open up the ileocecal valve to move the chyme from the small intestine into the large, we're also going to cause peristalsis in the large intestine. Now, those pockets are called haustra. So it's actually this peristalsis is called haustral contractions in the large intestine, and it's going to move the feces through the colon and out, right, out of the rectum. So when feces distends the rectal walls, you're going to get a contraction of the rectal walls. It's going to continue to move that feces towards the outside, and there's going to be an automatic or an autonomic relaxation of the internal anal sphincter, which is smooth muscle, and then voluntarily you release the external anal sphincter, which is made of skeletal muscle. There's a disease process called diverticulosis. It's the formation of these diverticula, which are small herniations in the wall of the colon. Diverticulitis is when those little diverticula get inflamed and infected. So bacteria might get trapped in there, cause inflammation. One of the dangers of diverticulitis, if it gets severe, is that it can cause a rupture of the colon. And then, of course, the feces will leak out with, and possibly cause sepsis in the blood. So this can actually be very dangerous. You can see here a picture of the diverticula, and so that's those little outpouchings, those little herniations in the colon. It can get really bad. Sometimes a section of the colon actually needs to be removed. If it's minor, it's able to be managed with diet, but this can become very dangerous if those little diverticula, as I said, become inflamed with diverticulitis. Now I'm going to sum up the next bunch of slides on this slide for the proteins, carbohydrates, and some lipid absorption, because it's all very similar and straightforward. You can look at those slides, of course, when you're studying. But proteins must be broken down to amino acids, carbohydrates into monosaccharides, and lipids in this portion gets broken down to glycerol, short-chain fatty acids, and medium-chain fatty acids. We'll talk about the absorption of long-chain fats on a different slide. But all of these, when they're broken down to their component parts, are going to enter the enterocyte, which is the intestinal cell. It's going to move through that into the blood capillaries, which will then be shuttled into the hepatic portal vein and go directly to the liver. So really, all of these are going into the cell, the intestinal cell, to the capillaries, hepatic portal vein, directly to the liver for processing. Now, the absorption of long-chain fatty acids becomes more complex, and we're going to go over that. Okay, this slide shows, if you look at the left villus there, it shows the short chain fatty acids, the medium chain, and the glycerol going right through the cell and going into the capillaries, hepatic portal vein to liver, which we covered on the last slide. If you look on the right side, it kind of zooms in. Now I'm going to go over it on the slide, and then we're going to list it out on the next page. I'm going to list out the 6 steps that I break this into. We cannot get, so there's 3 things that are going to move this way. We're going to have long chain fatty acids, which also includes very long chain, so long and above. Fat-soluble vitamins, A, D, E, and K, and also something called a monoglyceride. If you're not able to pull off one of the fatty acid chains on glycerol, it's called a monoglyceride, right? 3 fatty acid chains is triglyceride. So those 3 are going to absorb this way. They can't go into the enterocyte. They can't get in there. So if you look at this zoomed-in picture, we're going to package them into what's called a me cell. Okay, and the me cell, we're basically combining it with bile so that it makes it soluble, so it's able to enter into the enterocyte. Once the me cell is inside the enterocyte, we're going to unpackage the me cell, and we're going to take those long chain fats or fat-soluble vitamins or monoglycerides, whatever. We're going to take those, and we're going to form triglycerides from them. We're going to take those triglycerides then, and we're going to pack them into this structure called a chylomicron. The chylomicron, you can see on that picture there, that now is kind of a shuttle system, a mechanism to move these triglycerides. And so it's going to, you can see if we look at the actual picture where it's not zoomed in, right, so that right villus, you can see the chylomicron going into that yellow guy. That's the lacteal. Remember the lymphatic capillary I mentioned? It's very, very leaky. And so we're going to get that chylomicron into the lacteal, which is now in the lymphatic system. And it goes lymphatic system to blood, right? Because that's where the lymph system eventually dumps into. And that's how we get those long-chain fats, monoglycerides, and fat-soluble vitamins into the blood. Okay, so like we saw on the last slide, the long-chain fatty acids, the fat-soluble vitamins A, D, E, and K, as well as monoglycerides, we'll use this method to get into the blood. First, we will package them into a me cell. So by combining them with bile, make them soluble. The me cell will enter the enterocyte, which is the intestinal cell. We'll unpackage that me cell. We'll take the contents and form triglycerides from it. We'll take those triglycerides and we'll pack them into this lipoprotein called a chylomicron. That chylomicron is going to enter the lacteal, and once in the lacteal, which is a lymphatic capillary, now we're in the lymph system, and we travel through the lymph into the blood. The only thing I want you to focus on this slide is that 95% of water is absorbed by the small intestine, or in the small intestines, by osmosis. Gluten-sensitive enteropathy is celiac disease. And this is essentially an autoimmune disease, so go ahead and write that down. It's an autoimmune disease, and what happens is the body reacts to a protein called gluten, and it's actually a portion of the gluten called gliadin that the body reacts to and starts to damage the villi. And the treatment for this is to remove gluten from your diet. Now, where do you find gluten? Gluten is found in wheat, rye, and barley, and so by removing those products from the diet, it removes the offensive agent, and then the autoimmune response of destroying the villi stops, and the villi will eventually heal. So remember, there's no cures for autoimmune diseases, but this has a treatment of just not eating the gluten, which can be harder than it sounds, but that would be the treatment for it. Colon cancer is the second largest cause of cancer deaths among men and women combined. We know lung cancer is number 1 from the last chapter. Now, sometimes this is called colorectal cancer, so I use both terminologies. Colorectal sometimes gets combined, or just colon cancer, second largest cause of cancer deaths among both men and women together. Okay. You can expect to see artificial sweeteners and natural sweeteners on an exam. I don't know how many questions I'll put, 1 or 2, but I want you to memorize which ones are artificial, which ones are natural, so you can recognize them. And you have to know all the names. Aspartame is NutraSweet, is equal. That's one artificial sweetener. Saccharin, by the way, those are the blue packets. Saccharin, the pink packets, that's also sweet and low. Acesulfame K or acesulfame potassium, or acesulfame, I think it's pronounced. That is the, what color packets? I think they have yellow packets. Oh no, I'm sorry, they don't use those in packets. Sucralose, which is Splenda, those are the yellow packets. By the way, I'm not going to ask you what the color of packet is. I just want you to know the names. And the last artificial sweetener is called Neotame. So memorize all the artificial sweeteners and be super careful about sucralose and Splenda because people confuse it with stevia, which is on the next slide. That's a natural sweetener. Do not make that mistake. So your natural sweeteners are stevia. This is an herbal product and all natural. Honey is also natural. However, honey does have calories and a fairly high glycemic index of about 58. The other natural sweeteners are erythritol, xylitol, and maltitol. These are all sugar alcohols. They're not alcohol. They're actually sugars, or actually they're carbohydrates called sugar alcohols. So those are your natural sweeteners.